الصفحة دي عشان يعني أول واحد ستانلي فيل ده. ده البوزيشن البوست بتاعه أو السبيكر اللي هو ستانلي فيل. هو بس راح يشرب بقى.
بسم الله الرحمن الرحيم. Good morning everybody. To start with, I must mention that I missed my colleague and friend, Professor Srugi. And the second point, I want to thank my colleagues, the board of International Society, Egyptian Society for Bronchology, for this very eminent meeting, and I hope always we have successful meetings. The third important point, Dr. Maisa told me why you didn't mention, we published, I think in 1998, a paper in the International Journal for Aerosols in Medicine about the use of inhalational antibiotics in suppurative lung disease. And we can compare the use of inhaled antibiotics with systemic antibiotics and systemic antibiotics only. And I will bring to you a copy from this paper. And we use in this paper gentamicin, amikacin, nipsin, and crystalline penicillin. And it was very effective. The control study for I think 32 patients. It was very effective in managing patient with suppurative lung disease. Now we will start the session. I am so glad to join my colleague and friend, Professor Samiha Ashmawi, to co-chair this session about chronic obstructive airway disease. And definitely, as it's mentioned here for introduction of this session, that we have a very eminent speakers in this session. Now I just received a copy from the global burden report about the global burden of chronic obstructive pulmonary disease, which is mentioned, and it is the same in our country here, that COPD remains a serious global health problem. Burden of this disease impacts individuals and society with significant associated direct and indirect health care costs. There is an unmet need to optimize the management of chronic obstructive airway disease. The last estimation by WHO and the International Union Against Tuberculosis and Lung Diseases estimated now that 210 million of people worldwide have chronic obstructive lung disease. More than 3 million people died of COPD in 2006. This represented 5% of all deaths worldwide. Almost 90% of chronic obstructive airway, which is a very important point, COPD deaths occur in low and middle income countries, where effective strategies for prevention and control are not always implemented or available. Total deaths from COPD are projected to increase by more than 30% over the next 10 years without interventions to decrease risk, particularly exposure to tobacco smoke. In the Al Ahram newspaper today, this morning, we have a report that Egypt is one of the most endemic countries for tobacco use or consumptions, and finally COPD will still and will become the third leading cause of death worldwide by 2030. Now I will leave for my colleague Dr. Samiha to introduce the first speaker.
Well, first I'd like to thank Professor Tariq Safwat and Professor Ashraf Hatem for inviting me to share in this very elegant meeting. and I have the honor to introduce Professor Stanley Field. Professor Stanley Field is the Regional Chair, Department of Medicine, Atlantic Health, and Department of Medicine, Morristown Memorial Hospital, New Jersey in USA. He will give us an introduction and COPD in non-smokers. Please, Professor Stanfield.
Thank you. Again, thank you very much. I hope you're not too tired of seeing me up here, at least those that are back in the room. And again, I want to thank the organizers of this conference for having me, and again, compliment you on this excellent program. And I'm not complimenting you because I'm the first 3 speakers you've had today, but I think you've got a great round of speakers. And I'm really impressed at the workshops that have been laid out for the participants, which I think are really marvelous, done here at the university, which is a great show for everybody. So it's very nice. Some of the comments have already been made. I don't need to tell this audience about the global burden and what the issues are. And in fact, when the organizers asked me to talk, I was unclear. I thought they wanted me to talk about smoking-related COPD, and they really wanted non-smoking, which is a huge piece of the problem, and one that's probably recognized here in Egypt and other parts of Asia and Africa than in fact it is in the U.S. And so I'm going to, again, tell that story a little bit to you, but it's like bringing coals to Newcastle, and I don't mean that relatively or figuratively, because coal is part of the problem of biomass fuel and the issues around all of the population problems with non-smoking COPD. So the numbers are out there, whether they're 200 million or 300 million. I mean, it's not really that important how big of a problem, except it's big, and it's very big, and it's probably underrepresented. That's the key that we really need to know about. And we also need to know that we're limited even in our abilities to define the population very well. We talk in the U.S. all the time about, the need to measure FEV1. Well, we know that that's probably not very realistic. We've got a lot of surrogates for COPD, cough and sputum being one, but cough and sputum doesn't represent COPD. But if you add that number of patients, you get a lot of people who have some aspect of obstructive pulmonary disease. But clearly, we don't have these estimates correctly made, and there is an under-recognition and an under-diagnosis. Now, the next 2 slides you've seen and you've heard, but I'm going to repeat them because I think they resonate very much for everybody that's in the audience. So if you look at the ranking, COPD today, it's 5, it's 6. And if you move up to the next couple of decades, 2030, maybe 3rd, maybe 4th. But a better way to look at this is something that I think many of us have seen also. If you look at the major causes of death that occurred over the last 3 decades, they've all really gone down except for COPD. If there was any other disease process where the cause of death was going up the way COPD has been worldwide, it would be called an epidemic. And think about that. I mean, it really is pretty amazing. And we live this as respirologists all the time, but this kind of depiction really points out how far we are from making great headway, even though we've got pretty good drugs now, we've got good evidence-based guidelines, and we know lots of the causes. Smoking and non-smoking issues, which I'm going to go into for the next 10 minutes of this presentation, and we still haven't been able to combat this effectively. So, does COPD occur in non-smokers? The answer is yes. The question is, how great is it? And I think it varies in where we're looking. So it varies in women. I'll talk about that data in a minute. And it varies in which parts of the world we're looking at that account for this. And whether it's a third, if you pick a number, it doesn't really matter. Maybe less in the States, maybe greater in other parts of the world, but it's a big number of patients who do not smoke that have chronic obstructive pulmonary disease. And a nice paper, there's two very good papers that I'm going to quote in this. One is a 2009 paper from Peter Barnes, and the other one is one that just appeared in the Blue Journal this year that talked about some evidence-based. And the numbers are astounding when you look at this global burden. So this is the meat of the talk of what are the causes. And the causes we know pretty well. And there's evidence in varying degrees for each of these. But the big one in developing countries is indoor air pollution. And one of the things that was really incredible, and it may not be so incredible to you living in Egypt, and again in Cairo it's probably not a major issue, but before I came to the conference, I went out to Siwa, the oasis in the Libyan desert, and lived on the oasis in a place with no electricity, and they cooked and everything in a regular Siwa house. And all of the cooking is done with very poor chimneys, etc. And there is, you can see how there's major problems in the countryside here and in India and other parts of Asia from all of this biomass fuel and cooking. Then all the occupational exposures, farming, whether it's crop or animal, other dusts, chemicals, pollutants, and I mean just driving around in Cairo, Bombay, New Delhi, it's a huge issue for anybody that's aware of this. And then there are these other issues that are totally different. Non-treated infections in different parts of the world, lower respiratory tract infections in kids, chronic, that business we talked about before, chronic asthma that's irresponsive, or fixed airway disease, and then all this outdoor air pollution. And I added one to this slide, which I've experienced myself here in Egypt, is shisha and hookah, or hookah and shisha, or whatever you call it, I don't really know. But I was interested yesterday when the Minister of Health spoke. I couldn't understand all of it because it was in Arabic, but he gave some numbers for those of you that were here, talking about the prevalence in homes. I mean, I know I've gone to some of the cafes and seen, but that's a major problem. And with those water pipes, you don't really feel the smoke going in as much. So that's very prevalent now. And if it's up to 50% of the population, I don't know how much of the world smokes that, but even in New York City now, there are bars where you can go and do this, although it's very hard to smoke in the U.S. now, inside anywhere. And even there are laws now in the U.S. that are trying to prohibit smoking on open streets and on beaches. I mean, it's become that prohibitive. So it's a little bit to the right, but still, that's the way it is. So this is an example of a Siwa house, of open burning and coal, etc., without good chimney. There's some examples of cow dung. This is from India. I think this is from Peter Barnes' paper, where dried cow dung is used as a fossil fuel. And then this, again, is a very familiar look, particularly for me, and again for many of you, maybe when you were younger, growing up in different parts of the world here in Egypt, seeing the way cooking was done with small children being in the house. Now, what's the implication for children? We know about environmental tobacco smoke. Well, any of these factors can clearly affect the airway lumen, causing chronic bronchitis and chronic inflammation. But one of the things that we don't think about in relation to non-smoking COPD is the effect on the lungs in different parts of our life cycle. So clearly with whatever genetic factors we're born with, and that COPD gene that's been elusive or the asthma gene, clearly exists all throughout life. Air pollution and environmental passive smoking is throughout life, as is diet with antioxidants. Biomass smoke affects children, but smoking and occupation occur later and accelerate the loss of lung function at the end of life. So all of these things matter, but they matter different times for individuals. So there's data on ambient air, particularly in different parts of the world. I don't have any data here in Cairo, but you could imagine the data that exists in industrial centers in China and in Asia are very similar to what we would see here. The other issue about outdoor air pollution is its association on pre-existing disease, making exacerbations worse based on smog and particulate matter in the airway, in the air. And then the whole problem of fixed airway obstruction of asthma as another cause. So if you look at all of the occupational, the environmental, and then just fixed airflow obstruction from asthma and infections, we have a huge degree of disease processes. Now, does this disease differ than smoking-related COPD? The answer is maybe. I mean, we really don't know. And the difference in women probably does exist because it's a different disease in many women who have not smoked. And I think that's something that is seen in parts of the developing world where women may not smoke nearly as much as men, but are doing the cooking at home and have a much higher incidence of some of these problems. And are these patients responsive to bronchodilators? What about antibiotics being there? And what about their life expectancy? And we just don't know all of the answers. We can do things about it. And again, that's not the purpose of my talk as background, but clearly even when chimneys were put in those Siwa kitchens, it made a difference in the degree just by getting rid of some of the smoke that exists, realizing that the houses, the way they're built, are right next to one another, and the families congregate around those smoking-related rooms. And if you look at some of this data on, this is from India, I believe, the changes in COPD, depending on the type of cooking that was done, coal, and if you didn't cook, if you were a really lucky lady and had somebody cooking for you, you really were in pretty good shape there. And again, reduction, I'm going to try and save a little bit of time. So this is the other complementary paper to the Barnes paper that was just published by Elsner, and it's an environmental and occupational health assembly put together by the ATS looking at these novel risk factors for the global burden. And it just appeared this year in 2010 that relates to all of these, looking at asthma and TB cause definite abnormalities in lung dysfunction with irreversible airway obstruction. And although it appears that all of these other factors are evidence-based, more research is necessary in relation to outdoor air pollution, secondhand smoke, biomass, diet, and chronic asthma. And again, the genetic polymorphisms of basic COPD are important here. And the environmental smoke of tobacco is also key. So I think we have a lot of information that tells us about all of the non-smoking conditions. There's a lot we can do about them. The real issue for all of us as respiratory physicians is how and what we can do based on the countries that we're from and how hard we want to approach these problems. So stop there. Thank you.
Professor Stanley, thank you very much for your excellent introduction about the very important topic, chronic obstructive pulmonary disease. And as you mentioned, it's not only smoking is the main precipitating factor of chronic obstructive pulmonary disease, and also we are complaining in Egypt and maybe in the Middle East from pollution, atmospheric pollution, and also indoor pollution, and the use of biomass fuel is increasing in this area in different countries, so that we have many factors which is leading to this chronic problem in the region and all over the world. And I think after all the presentation we have more longer discussion. Now it's my pleasure to introduce, thank you very much. في الآخر. You want to leave? Okay.
No, I think there was a question, yes?
Yes.
Oh, I'm sorry.
Thank you.
Oh.
تفضل يا بيه.
We used to say, that COPD means chronic bronchitis and emphysema. And we used to classify emphysema as centrilobular and pan-acid. I haven't heard the word about alpha-1 antitrypsin. Has it been dropped? And the pan-acid emphysema, has it been dropped from COPD? Or would still consider alpha-1 antitrypsin and pan-acid emphysema as a part of COPD?
Yeah, it's all part of COPD. It's all part of COPD. I think there's less descriptive term now in relation to the anatomy, but more of an interest in the phenotype of the patients that are presenting as to whether they exacerbate or not exacerbate and how they respond to treatment in looking at the disease process. But all of that relates to COPD. But you're right, we don't use those terms very much anymore.
It hasn't been dropped?
It hasn't been dropped. It hasn't been dropped, no.
It hasn't been.
Alpha-1 antitrypsin deficiency is important, genetic factors are important, imbalance between proteases and the anti-proteases, imbalance between oxidative and the antioxidative states, all of these factors are important as underlying precipitating causes.
Genetic factors?
Yes.
Genetic factors. But why did I hear a word about it?
أنا قلتها عشان حضرتك ما تزعلش. Now it's my pleasure to introduce Dr. Islam Ibrahim. Dr. Islam is the head of the Internal Medicine Department, International Medical Center, Jeddah, Kingdom, Saudi Arabia. Please, Doctor.
Good morning, everyone. I'd like to thank President, Organizing Committee for the kind invitation, and I'm personally proud of being a graduate of this great School of Medicine. I'm going to try to take you on a 15-minute ride around the globe to talk about some of the challenges that face physicians in the management and treatment of COPD. Our knowledge now shows that COPD is not only a preventable disease, but also potentially treatable. These are some of the challenges that I'm going to mention today. The rising mortality, and Professor Field made my job very easy because he had already talked about that. COPD remaining underdiagnosed and undertreated. The estimation of the burden of disease remains a challenge for many societies around the globe. We have a diagnostic challenge. We have a challenge in implementing the guidelines, in preventing the disease, and in overall management. You've seen a similar slide, and the finding is, in spite of progress in many other areas of medicine, we still have a rising mortality, and you'd see the slide, Professor Field showing that. Here's one of the first problems we see, even in the U.S. and Western countries. The public knowledge about COPD is very poor. And this is a study that was conducted in the U.S. and Europe. And it showed that the public awareness was only about 23%. Only 23% of the population knew what COPD was. And when the study was conducted in other countries, Germany, Brazil, mainland China, the results were even worse. That's another slide showing that people did not recognize that COPD was a disease of the lungs. So we have, the first challenge is educating the public. Not just the public, but even primary care physicians. You're going to see on a slide here in Australia that 85% of COPDers are being managed by primary care physicians. And this slide is showing that 70% of primary care physicians are not aware of guidelines. When we try to estimate the burden of disease, well, to plan effectively to treat any disease, you need to understand the size of the problem. And in trying to do that, we have the BOLD study that looked into 12 different countries, trying to come up with the prevalence of COPD. This was based on a questionnaire and later confirmed by spirometry using standard technique. And the results showed that COPD prevalence is right about 10% in males, maybe a little bit less than males for females. But it also showed something else which was very interesting. It showed variability. Prevalence of COPD among Chinese women in Guangzhou was about 5%, while it was about 17% in South Africa. Also for men, major difference, about 10 to 12% compared to about 23% in Cape Town, South Africa. A similar study was conducted in South America looking at these 5 countries with more than 5,000 patients recruited. And the findings are staggering. You see that the prevalence in certain areas like Uruguay had reached 27%, contrary to our belief or understanding that the prevalence of COPD is about 5 to 10%. The same variability again was shown. 11% to 12% difference between Mexico City and Montevideo, Uruguay. Another population-based study in the U.S. estimating that population over 18 years of age had about 14% prevalence of COPD. But the good news is majority of these patients are in early stages. Only about 1.4% of those were gold stage 3 and 4, which puts a lot of emphasis on early recognition and treatment of the disease. This is another slide showing our cumulative knowledge now. When people smoke, the incidence is about 15%, probably the prevalence. The older the population, the more COPD we have, 15%. Again, variability between the prevalence in men and women, almost double in men. And there is clear evidence of a difference in prevalence between developed countries and developing countries, mostly in Southeast Asia and in South Africa. So now we understand that the older the population, the more COPD we get, the more smoking and tobacco use, the more COPD we get. But as Professor Field talked about, the exposure to other important factors in the developing countries that are not well recognized in the Western world, biomass heating exposure, occupational exposures, as well as endemic lung infections, particularly TB. It's a sad fact that smoking continues to rise in areas like Africa and Southeast Asia. And it is expected that the prevalence of COPD will continue to rise, even in the US and Europe, for the next 20 years. But then it will reach a plateau. But that's not the case for Africa and Southeast Asia, where the disease will continue to rise for the next 40 years. In China, there was a remarkable jump in the prevalence of COPD from 3% to 10%. Similar findings also in Japan. So COPD risk factors, in addition to tobacco smoking in the developing countries, we have talked about exposures, both indoors and outdoors, respiratory infections, particularly TB, and also malnutrition. which in itself is the risk of dying from COPD. That's why it is not surprising to see mortality rising in sub-Saharan Africa, projected to reach 25% in year 2015, which means 1 out of every 4 COPDers will be dying with that disease. This is also disability-adjusted life years, and as you can see, high numbers in developing countries compared to the developed world. The numbers particularly are very high in Southeast Asia and in South Africa. There is the economic challenge as well. People who have debilitating COPD are forced out to the workplace, and not alone. They usually take a family member with them to care for them, since the system is not set up to take care of these patients at home. And for countries that depend on human capital, that is a big hit to the economy. This is just a slide to show you how expensive COPD can be. It costs up to 4,000 euros to take care of one case of severe COPD hospitalized. Most of that money goes to hospitals during exacerbations. The red part of the bar represents expenditure on medications. The blue part represents hospitalization expenses during exacerbation. So if you want to do an effective job with a COPDer, keep them out of the hospital. Treat them before they get into a full-blown exacerbation. That's the message. In Japan, the cost is anywhere between $4 to $8 billion spent annually on exacerbation treatment of COPD. Now, I'm talking about our area now, Middle East, developing countries. There is a great sense of that region being left behind. There is not much information coming out of this world. And access to health care by citizens of these areas is very much limited and sometimes unavailable. So the adaptation of the globally developed guidelines becomes very challenging with these facts. And the question is, do we have well-established guidelines in the developing countries? And I found that picture, which probably represents the status of those guidelines in many of these countries. So in these areas, about 15% of the population in South America have no access to health care. Maybe 1/3 in the Middle East, and more than 40% of the population in Southeast Asia. I found that amazing picture, and I was wondering whether this man was making a phone call trying to get the most up-to-date guidelines on smoking cessation, but I didn't think so. It is a sad fact that only wealthy minorities and the privately insured patients do have full access to health care. Nevertheless, the WHO had developed this reasonable, practical approach to management of COPD called Adult Lung Health Initiative, which focuses on development of national guidelines, training of local professionals to take care of disease, implement preventive programs, and really go after the tobacco epidemic. With that, some guidelines have been developed in developing countries, but most of them are based on expert opinion rather than evidence-based medicine. And that's because lack of clinical trials in these areas, and rightfully so. Clinical trials are very expensive. If you wanted to design one study to show the effectiveness of early treatment of COPD, you would need to recruit 1,000 patients, follow them for 3 years at a cost of tens of millions of dollars, which most developing countries cannot afford. Challenge of diagnosing the disease. We know from the GOLD criteria, we depend on spirometry. But what happens when spirometry is not available? We have to take other surrogates, clinical diagnosis based on history and physical, dyspnea scale, peak flow, and other things. How accurate is clinical diagnosis compared to spirometric diagnosis? In this particular study, out of 9.2% having COPD, only half of them were diagnosed. So we're still missing half the patients when we only use clinical data. This is a study in Australia showing that half of the patients here were missed by clinicians and were not given a diagnosed COPD. When you ask the patients, have you ever seen a doctor for asthma or COPD, half of them will say yes and half will say no. If you had pulmonary function test, only 1/3 will say yes. If you had been seen by a specialist in the past 12 months, only 15% will say yes. If you are given regular appointments with a doctor, only 10% will say yes. Influenza vaccination, 66%. Pneumonia vaccination, about 40%. Gold criteria is so nice in demonstrating staging of disease and treatment. Nevertheless, the practical approach for developing countries looks something like this. Number one, you do not give expensive medications. So as you will see in this algorithm, inhaled corticosteroids do not appear until you're in stage 4. And only when you demonstrate responsiveness to steroid treatment, you are given inhaled corticosteroids. We know that inhaled bronchodilators are more effective than oral bronchodilators. Nevertheless, we still see a lot of oral bronchodilators being used simply because of the cheap cost. The cost of medication is not a joke. In some countries, the cost of medicine per month exceeded a whole salary of a nurse for that month. When we try to prevent COPD, our goals are to help patients cope with the disease, quit smoking, use inhalation properly, but that again needs expertise, time, resources, which is very challenging in the developing world. We need to limit the exposure. What we do for the patients is that we counsel them, we help them change their behavior, but we also prescribe medications, antidepressants, and nicotine replacement. In most of the developing countries, the medicine is either not available or just not affordable. Biomass smoke, and you've heard enough from Professor Fields, so I will not repeat that, but non-smokers do develop COPD, as you just heard. And you've seen similar pictures of indoor exposure. Outdoor exposure, although most of the patients would love to blame their COPD on environmental factors, it is less important than indoor exposure, accounting for 1% of COPD in the developed countries and 2% in the developing nations. We also understand the role of infections in development of COPD, especially when they happen early in life because of the structural damage, bronchiectasis, and the change in the airway responsiveness. And also, most of the exacerbations that put patients in the hospital, and very costly, are caused by bacterial and viral infections. We understand the value of the influenza vaccination, been shown to reduce serious morbidity and mortality by 50%. Nevertheless, it is not widely implemented in developing countries because of knowledge gap, because of different seasons, because of lack of effectiveness cost-saving studies that would clearly show the benefit. Time is up. Can I get an extension? Can I get 1 or 2 minutes?
I think we can use 2 minutes during discussion, and thank you very much for your excellent presentation.
Thank you.
Thank you very much, Professor Islam Ibrahim, for this elegant presentation. And now we are very lucky to have with us Professor Stanley Field, who will speak with us, give us this lecture, How Safe Are Our Drugs for COPD?
When he gets the slides up in a second. So you've heard a lot about the burden and the problem of COPD. And the issue exists around these guidelines. And I think it was very nicely shown that we've got guidelines, they're evidence-based. Do we follow them, do we use them? Cost is an issue. It's very nice for Europe and the U.S. to talk about evidence-based guidelines when the real world, for a lot of the world, understands that, but doesn't have the wherewithal to use them. So what's practical for different people? So that's one issue that I think you understand. But the other important factor is how safe are these drugs? And so I want to address it because we've got the guidelines, and boy, they look fine. They come in all different colors and all different flavors, and they just seem so perfect for teaching medical students. And that's kind of the best way to use them, to at least get a stability of what's out there on data. Well, as these drugs have been out for whatever period of time, there have been a lot of experience with them, and as we've developed issues over time, we realize that there are potential problems. And if you think about the problems that exist, they exist in elderly people who get COPD, but elderly people. And because of that, there is this concern, are we doing more harm than good? So I'm going to give you my simple opinion first. No, we're not doing more harm than good. I think the drugs work. They're very good. They're extremely safe. And there's been lots of pot shots taken at them and questions about them, appropriately so. But I think you can feel comfortable knowing that there's a lot of data out there from randomized trials that really let these drugs be used comfortably by you as you use them. So that said, I'm going to spend the next 12 and a half minutes going through the ups and downs historically of what we know about this to make the point. But the bottom line is, I think the drugs are safe. There'll always be post-marketing data. We've seen so much in diabetes and heart disease of any of these drugs. The longer drugs are out, after they're used, issues can come about them. But by and large, they're pretty safe. So I'm going to look at the SABAs, the LABAs, the LAMAs, and inhaled corticosteroids. And when you look at drug safety, there's the classic randomly controlled trials, the meta-analysis of randomly controlled, and then the observational studies, the insurance records, the national registries, and administrative databases. And I can tell you that the statistics around all of these are way over my head. They're probably over a lot of your heads. They're very difficult to understand how these data get generated. We just look at the summaries frequently in the studies, but there are many ways to look at this information. That said, not just from the guidelines, we know that drugs used for COPD over this last decade have come a long way, and that long way really relates to improving symptoms, improving lung function, improving quality of life, decreasing exacerbations, and probably decreasing mortality, although the question mark exists around that, because Uplift and Torch never quite hit their endpoints exactly, but got close, and at least led us to believe that we probably can have some impact in mortality as well. So we can do a lot of good with these drugs, and from a risk-benefit ratio, are they worth it? Well, if you put the background of COPD on the population we're looking at, COPD increases risk for lots of different things, and that risk ratio is big in all of these other areas. So whenever you're talking about using drugs and treating, you've got a background of significant morbidity and mortality that relates to cardiovascular disease, particularly with COPD. The short-acting beta agonists have been around for a long time. There's always some question, do they cause arrhythmogenicity, but are they safe? And I think overall the answer is they're safe. Yes, they can increase heart rate, they can give palpitations, they can give tremors particularly because of the beta effect. But there's not a lot of data for significant ventricular arrhythmias, and we don't use them classically in acute myocardial irritability or MIs, but they're probably pretty safe, and there's really no good data that they increase mortality from the short-acting side. The anticholinergics, as we talked about earlier, asthma, COPD, dry mouth, intraocular pressure, outflow obstruction, Those are potential problems, renal insufficiency. But the big thing that came up in the last couple of years had to do with cardiovascular safety. So again, rearing its ugly head in some of these retro meta-analysis was the concern over the shortening refractory period and safety in cardiovascular disease. And looking specifically from this epidemiologic study of a large database of patients controls to COPD, if you look at heart failure, you can see that the risk ratio for cardiovascular mortality in basic population of COPD, irrespective of heart disease, is over twofold. So the background of this patient population, and again, I'm not telling you anything you don't know, but when you're looking at controlled studies, you need to know that background before we start talking about the drugs are causing the problem. Is it the disease itself that's the issue? And again, we're not always sure. So overall causes of death in TORCH, we know, were respiratory and cardiac. So over half the patients were cardiorespiratory deaths in TORCH itself. And the smattering of cancer and some other issues were involved. The safety of LABAs had been questioned really in '06 with this paper by Salpeter that looked at 22 randomized trials of patients with COPD. And what I'm going to do is just lay that fact out there. So short-acting short-acting anticholinergics are probably safe, or there's some of those issues. The short-acting adrenergics are probably safe, again, except for maybe acute cardiac irritability. But the long-acting bronchodilators were questioned significantly. And then there was opposing studies that came out in '08, one by Rodrigo and another one by Kleber, in looking at big databases, much bigger than the Salpeter study, that really blessed the LABAs in COPD such that LABAs by itself do not affect all-cause mortality in COPD. I think finally we've put the LABA story to rest in COPD. And these two studies nailed it, notwithstanding these other issues that were surfacing in the literature. Now, what about the LAMAs and the anticholinergics? Well, just like the Salpeter paper, there were some concerns over the safety of the anticholinergics. And Singh published a paper in JAMA about the use of inhaled anticholinergics with significant risk of major AEs, cardiovascular particularly, and stroke. So this was a big concern for a very important drug that occurred. And I'm going to read the next couple of slides, which I thought were extremely important in putting the LAMA story to rest. And the LAMA story was addressed by the Paddock of the FDA just a couple of months ago. And this drug occurred November '09, it was done a year ago, but published in 10, using Uplift as a large 5,000 or so patient randomized controlled trial of tiotropium. And the data on the deaths was collected prospectively. The causes were adjudicated by independent committee, and there was no adverse effects found for TIO in the Uplift trial. And because of the strength of the Uplift data, the absence of a strong signal there related to stroke or cardiovascular events, and the potential methodologic limitations of these retroanalyses or meta-analysis, the FDA concluded that current data do not support the conclusion there's an increased risk of stroke, heart attack, or death associated with the HandiHaler, that delivery device. Now remember, the delivery devices may be different, but this is important to get all of this crisscrossing information, and I think this was a nice summary by the FDA. So they went on to say, we've entered an era of increasingly frequent publication of meta-analysis, some of which identify potential safety signals. That's legit. But such publications commonly leads to urgent calls to take immediate regulatory action without acknowledgement of potential pitfalls in the interpretation of data from these meta-analysis and pooled analysis, such as those encountered in this study. So I think there's great lessons as far as LABAs and LAMAs are concerned with COPD and the background that exists, that they are safe in this particular patient population. Is it the entire story? No, because things keep popping up. And so what just popped up was this beta agonist candesartan study. This was not a COPD trial. It was a heart failure trial looking at patients with heart failure, looking at a new beta blocker called the CHARM study, and adverse events were noted particularly in those patients with heart disease and who were getting bronchodilators. So now this raises its ugly head again, specifically in patients with heart disease. And if you look at their information, those patients who had no bronchodilator and heart failure with the beta blocker had a much better survival than those who got bronchodilators. This is LAMAs or LABAs. So although we just thought we'd put everything to bed with the FDA, CHARM came out with a new concern for everyone. And they concluded that bronchodilator use is a powerful independent predictor of worsening heart failure mortality in many patients with heart disease. But whether this relates to the toxic effect of the bronchodilators, underlying lung disease, or both is unclear. So what can we say, I think, is that it's probably safe. One should be careful in using bronchodilators in patients with advanced heart disease, but again, it's a risk-benefit ratio and one that's probably worth it. I don't have very much time left. I'm going to just say a word about inhaled corticosteroids, and basically the issue with steroids has been the pneumonia signal, and the pneumonia signal has been pretty confounding but pretty consistent, and there seems to be no question that there is an increased risk of pneumonia when one looks at inhaled corticosteroids with or without LABAs in COPD. And I think that's something that we're aware of. It does not affect mortality, however, although there is this issue, and it probably occurs with higher doses that have been used than with lower doses. There's also no issue, it seems, with fractures or ocular abnormalities with inhaled corticosteroids. So current evidence favors the use of our standard therapies. Cardiovascular risk and risk of mortality does not appear to be excessive with LABAs and LAMAs. However, certain subgroups, maybe some of these advanced heart disease may be at risk. We just don't know. And inhaled corticosteroids may have some risk, particularly in higher doses with pneumonia. So I think we can be comfortable continuing to use our guidelines, whether we amend them for emerging economies, understanding the limitations. I think that's a great example that we had from our prior speaker in relation to what one needs to do in different countries. But nevertheless, one can feel comfortable using what we have based on the data that exists today. Thank you.
Thank you, Professor Stanley Field, for this up-to-date lecture. And now I have the honor to introduce Professor Khilnani, who is a professor of medicine, All India Institute of Medical Science, New Delhi, India. He will present to us COPD in India.
Honorable Chairpersons, ladies and gentlemen, I come from a country which is, how do I run the slides, please? Excuse me. How do I run the slides from here? I come from a country which is probably well known to you, and there is something in common between Egypt and India, that we own wonders of the world. And you have pyramids, we have Taj Mahal. So something in common, and we are quite a populous country. Sorry, I am unable to move this. This one, okay, sorry. I got it, yeah, all right. I work at the All India Institute of Medical Sciences, Delhi, which is a premier institute of the country, known for its education, research and clinical work. And part of my talk, the topic given to me was spectrum of COPD in India and its management. Quite a lot of it has been talked about. So I'll be skipping a whole lot of slides, focusing on India. And just to tell you that India is a diverse country. There are very poor people. There are very rich and affluent people. There are people who don't have access to the medical care. And there are people who enjoy the world-class health care. I am a pulmonologist with a special interest in intensive care. And I have done some work in non-invasive ventilation and COPD, and have conducted 2 randomized controlled trials besides writing about non-invasive ventilation. So I'll be touching upon them. Now somehow in Asia, the WHO report said that highest smoking rates are in Asia, which is projected to increase. And if you talk about COPD in India, that I'm supposed to talk about, if you talk about Asia, the incidence of COPD is 4.1%. If you talk about Japan, it's something like 10.9%. Why there is such a difference? Whether that difference is real or not so real. And this is about prevalence of tobacco use among Indian women. As I said, India is a huge country. This is a northeastern area where the use of tobacco is something like 25% among women. Tobacco chewing is something like 60%. And there is a northern India in Delhi where I am working. The incidence of smoking is something like 2% or 3%. And why the Indian women have so much of COPD? And there are variety of tobacco smokes which is used, the cigarettes, the bidi, the cigar, and so on and so forth. And this is the bidi. What is a bidi? It's the most common smoking which is done. This is just a tobacco which is rolled up in a leaf and tied up with a string. And all the labor class people, all the poor people, they smoke a large quantities of bidis. And studies have shown that harmful effects of bidis is as much as cigarettes. Now this is an Indian woman who cooks for all through her life with a cow dung cake or wood, and smokes this, inhales this. And this is the reason that Indian women get COPD. Now this is the crowded area of city of Jaipur, if you have heard of that, and there is an immense air pollution. As I entered Cairo, I thought I had entered Mumbai. It had high-rise buildings. I could smell the air pollution as much as I smell in Mumbai, because this has been my research area. Now, coming to what does it do? What does the smoking does? What does the air pollution does? What does the indoor air pollution does? It causes small airway disease. It causes parenchymal destruction, leading to airflow obstruction. The airways become so narrow that when you do a spirometry, there is diminution of FEV1. This all has been talked about. So I would sort of skip it and focus on what I've done research on. This is the X-ray. Now gold guidelines have been talked in detail. I wish I had the program before so I could have removed all those things. Now coming to the COPD exacerbation. That has been of my area of interest. For some reasons not known to the researchers from 1991 to 2003, this is a study published in Lancet, that this incidence of exacerbation of COPD has been increasing. Whether it's real or something has happened, we don't know. And quite often these patients are landing into the intensive care unit. In fact, in our ICU at the All India Institute of Medical Sciences, New Delhi, COPD is the commonest cause for which patients are admitted into the ICU. Of course, we have 32 ICU. Now, when you talk about management of COPD in intensive care unit, it involves oxygen therapy, pharmacotherapy has already been talked about. Non-invasive ventilation has been the biggest development in this area. And of course, invasive ventilation I am not going to talk about. There is role of infection and there is role of systemic corticosteroids. This is a small machine. I am sure you people are using it here. It's a non-invasive ventilation. What you do is that instead of using an endotracheal tube, you use a face mask to give positive pressure ventilation. And Brochard was the first one in 1990 who came out with the idea that non-invasive ventilation, when used in COPD, it increases the tidal volume, it increases the respiratory rate, it improves the gas exchange, it reduces the need of endotracheal intubation, it reduces the duration of mechanical ventilation, and it reduces the ICU stay. So it took for years for the community to infer that non-invasive ventilation is a useful modality. We at the All India Institute conducted a randomized trial to find out the role of non-invasive ventilation for exacerbation of COPD. We studied 40 patients prospectively. It was perfectly randomized trial. The person who was conducting the trial did not know, was carrying sealed envelopes. Now, what is important to highlight in this study was that mean PCO2 was 82.3. Now, you might say why? None of the studies that I have reviewed all over the world had the admitting PCO2 of 82.3. We at the All India Institute have a resource crunch. We get millions of patients, we are able to admit few. And I would admit here that there is some delay in admission. The patients come late to us, but even those patients with 82.3 PCO2, we gave them non-invasive ventilation, and I will just show you the results. These are the data in the control group and NIV group. They were absolutely comparable, denoting that the randomization was good. This is the summary of the result. As I told you, the admitting PCO2 was more than 80. Within an hour's time, there was significant reduction in the PCO2, within an hour's time. And by 24 or so, it plateaued. And we looked at the pH. There was significant improvement, that is increase in the pH, close to the significant. With the p-value of 0.07, there was significant improvement in pH within an hour of the study. Since it was a prospective study, everything was done at 0 hours, 6 hours, 24 hours, and every day the ABG was done. And what were the results? When we treated 40 patients, randomized them into a non-invasive ventilation and conventional therapy, the intubation was done in only 3 patients in NIV group and in 12 patients in conventional group. So, however, there was no difference in the mortality. So 12 of the 20 patients in the conventional group required intubation. 3 of the 20 patients in NIV group required ventilation. So by giving NIV to 20 patients, we were able to avert endotracheal intubation in 9 out of 20 patients. There were lesser incidence of complications in patients with NIV. However, there was a shorter ICU stay. However, there was no difference in the mortality because the sample size was too small. This is a study that this is the review article that we wrote in the International Journal of COPD, summarizing all the studies which were done till 1998. And what was the conclusion? The conclusion is that NIV should be considered in patients of COPD in addition to standard medical therapy when they present with acute exacerbation, provided they satisfy the inclusion and exclusion criteria. Because not all the patients with COPD exacerbations are candidates for non-invasive ventilation. Stimulated by these observations, we thought, can we use NIV for weaning? Because our patients with NIV sometimes were ventilated for 1 month. It was difficult to extubate them. If you were extubating, we had to reintubate them very often. So we conducted another randomized trial using 40 patients. After the extubation, immediately after the extubation, half of the patients were randomized to receive non-invasive ventilation. Half of the patients were randomized to receive conventional treatment. What we were looking at? We were looking at that after we put the patients on non-invasive ventilation, there will be reduction in the rate of reintubation, which is a big problem in our ICU. What we found that in patients who received non-invasive ventilation, 3 patients required reintubation, and those patients who were put on conventional therapy, 5 patients required reintubation. This was statistically insignificant. We reviewed the world literature and it is still not certain. It is still not certain whether NIV is a useful modality after extubation. So what was the current status? Almost all randomized studies support use of NIV. Both hypercapnic and normocapnic patients respond well. Hypercapnia and level of consciousness response rapidly can be tried in patients with altered level of consciousness. Some evidence of late onset respiratory failure can be seen in these patients. Now when these patients go on an invasive mechanical ventilation, that is, they are requiring intubation, and believe me, as the patient goes on endotracheal intubation, the 50% hope of life is already gone. Now these patients, this is the data, that at the end of 1 year, the survival percentage is something like 60%, 24%, 57%, 44%. So on an average, 50% patients will be dead at the end of 1 year. So we thought, let us find out what are the predictors of intubation. I will quickly go through it, my time is running out. We found out in a prospective study that the biggest predictor of mechanical ventilation was age, low pH and hypoalbuminemia. It was not PCO2, it was not PO2, it was not FeV1. Now we also tried to find out what were the predictors of mortality. Which are the patients most likely to die? There were 82 patients. This is a published article, and we found that high Apache 2 score and serum albumin, they were the most predictors of mortality in patients with COPD requiring mechanical ventilation. So it was not PCO2, PO2, it was not the pH. So what is the conclusion of our talk? The conclusion is the prevalence of COPD is high both in men and women in India, in women more because of indoor air pollution. All patients must receive bronchodilators. NIV should be modality of choice whenever they come with exacerbation and there are no contraindications. All patients should receive antibiotics. Systemic steroids, I have not talked about, have got definite indication in acute exacerbation of COPD. There is sufficient evidence. Long-term oxygen therapy improves survival, and there is increasing role of rehabilitation, which I have not talked about. Ladies and gentlemen, Chairperson, thank you very much for your attention.
Professor Khilani, thank you very much for your excellent review. about your deep experiences managing patients with chronic obstructive airway disease in India. Now we have sometimes very short time for discussion. I will start question to Professor Islam Ibrahim about the role of vaccination in prevention of exacerbations in patients with chronic obstructive lung disease.
Well, in my slide, as I showed, that the lack of studies on effectiveness prohibits the lawmakers and decision makers from implementing that influenza vaccination as a routine. For example, it is not applied as you would do polio, for example. And that big gap leaves it open for the interpretation by physicians. And eventually, whether to give the vaccination or not is left up to the physician. And that's the reality we see in the developing world. But in the developed countries, influenza is so much pressed in the management of COPD. For example, in the workplace, you will see that influenza is administered free of charge to most of the employees in workplaces. And that's because those studies had shown that there is evidence that implementing the influenza vaccination will reduce morbidity and mortality in patients with COPD.
Thank you. Any questions? Please.
I'm not a practicing physician, but I noticed that most of the patients, or a good percentage of the patients using inhalers, do not use it properly and they don't benefit from it. As a result of this, they double the dose or triple the dose prescribed by the physician, and at the same time being expensive, it's not regular, and it's extremely important for somebody to take over the possibility, the initiation of teaching those patients to use properly their inhalers. What are we going to do about this?
You are absolutely right. And I think one of our very important jobs is to educate the patient how to use probably the inhalers. Whatever it is, meter dose inhaler or turbohaler or any one of the, or handyhaler, etc. And now the inhalers are one of the important methods for administrating the medications for patients with chronic obstructive lung disease or bronchial asthma. And as you heard, the management of chronic obstructive airway disease is not only the pharmaceutical drugs. Today, and I think 1 month ago, we were here in this center, and there is always a debate between long-acting bronchodilators or anticholinergic drugs or combination of both. But this is important issue in the management of COPD. But management of COPD is multifactorial. It needs prevention. It needs long-term treatment. It needs education of the patients. It needs preventive measures like vaccinations and also rehabilitation, etc. So that your issue is very important, and I think, and it's important that training of the patient is very important, how to use his breath and how to use the medications.
Sir, may I add to that? There was a study which has said that in the outpatient department, it takes 3 minutes extra over and above your usual consultation to have a proper teaching and training of inhalers. As far as the COPD patients are concerned, in our experience, if you are using MDIs, multi-dose inhalers, in my experience, most of the time I am using MDIs with spacer. Without spacer, these elderly patients are unable to use MDIs properly. I am not a proponent of nebulizers because nebulizers add to the toxicity, and the dose given is at least 20 times higher.
Any other questions or comments? Okay. By the end of this session, I do thank you very much, the audiences, the attendants, our professors, the speakers, and my friend and colleague, Professor Samiha Ashmawi. And also, again, I do thank Professor Ashraf Hatem, Professor Ahmed Al-Halafawi, Professor Tariq Safwat, Professor Adil Khattab, and thank you very much.